Good afternoon and welcome to the mental health of the Latinx community. I am Leonora Garcia, the Director of Gift Planning at the Community Foundation for Greater New Haven. Since 1928, the Community Foundation has inspired individuals, families, and businesses to have charitable giving aspirations that positively impact the communities where we live and work. Before we start, I ask you to please use the Q&A function at the bottom of your screen to ask your questions during the program. If you're having some technical issues or connection issues, please use the chat function. At the end of the program, you will see a survey pop up on your screen. Please take a few minutes to give us feedback, which helps us to continue quality programming. Here to introduce our panel today is Jadi EJ. Jadi is co-chair of the Progreso Latino Fund and program director at the Department of Children and Families with the state of Connecticut, where she's been for more than 2 decades. Jadi received her undergraduate degree from Southern Connecticut State University and her master's in social work from Fordham University. She is a native of Bridgeport and currently lives in New Haven with her husband and 2 children. Please join me in welcoming Jadi.
Buenas tardes, good afternoon. The Progreso Latino Fund is an endowment fund that was created in 2003 to promote the educational and socioeconomic well-being of Latinos in New Haven and the region. PLF carries out its mission and creates change through forums like this, through celebrating Latino leaders in our community, providing grants to programs and services that advance Latinos, and focusing on youth and young leaders. Joining us today to moderate this panel is Francis Padilla, the president of Universal Healthcare Foundation of Connecticut. We also have with us panelist Tara Davila, who is also co-chair of the Progreso Latino Fund and serves as the associate director of youth services at the Yale Child Study Center. Brian Padilla is joining us. He is the behavioral health director at the Fairhaven Community Healthcare. And Leonora Rodriguez, executive director of the Milford Senior Center. I will now turn it over to our moderator, Francis Padilla, who's the president of the Universal Healthcare Foundation of Connecticut.
Good afternoon, everyone. I'm delighted to be here today and very pleased that we are taking up this, this important topic. We have really in recent days, the media has been focusing a lot more attention on the mental health crisis that we are seeing in the United States, and I would venture to say worldwide. I would invite our panelists to actually turn on their cameras so that we can all be together in this conversation. Thank you. And here in Connecticut, of course, we have been seeing evidence of increased mental health needs in communities across the state. These needs, of course, are not new. A lot of the impact of the COVID pandemic has certainly exacerbated these needs, but they certainly are not new because in reality, in our approach to health, we have not really attended as well to the mental health needs of our folks as we might physical needs. And that is a truth around how, as a society, we deal with mental health needs and mental health care. But today, we are going to take a deeper dive into what it is meaning for the Latino community, and particularly the Latinx community of Greater New Haven. We have in the folks that are speaking with us today, really perspectives that cover the lifespan. So Tara will talk from the children and youth perspective. Brian will talk about the adult perspective, and Leonora will talk about the elder perspective. And because we are whole human beings, we start and we progress, it's really very important that we think about it from childhood through adulthood and our elder years. So I'm excited. We're not going to have enough time, I know this already, for a full discussion, but we are going to provoke thinking. And I'm going to turn it over to Tara. And Tara, you've got a few minutes to give us some highlights of what you want us all, including our audience, to be thinking about.
Thank you, Frances. I'm so glad that we're having this conversation together, and thank you all for joining us today. So I'm Tara Davila. I am a licensed clinical social worker, and I've dedicated the last 20 years of my life serving the historically marginalized children and families of Connecticut through direct clinical practice, supervision, advocacy, and clinic administration. So when I decided to become a clinical social worker, my father wondered why I wanted to listen to the problems of rich white people. He did not think that I would ever end up meeting my goal of serving my community, because as a culture, we keep things entre familia. And so 20 years later, his perspective has evolved. And I've also seen the same evolution within our community. So there's more openness to receiving services. But despite that shift, only 8% of Latinx children have ever engaged in behavioral health services, as opposed to 14% of white children. And while that stigma has decreased somewhat, which is a great thing, there is still the very real challenge of not having enough clinicians who can provide culturally and linguistically appropriate services to the Latinx children and their families. And so we have many things that we can think about in this, but I know for over the years that I've been in practice, it's been a consistent struggle to find higher levels of care to support children for whom Spanish is their first language. Even if they're bilingual, their first language is the language of their emotions. So they're then forced to translate their emotional experience, which English-speaking peers don't have to do. In addition, the parental component of these services is often not available to their monolingual parents. And colleagues have shared with me that even though there are interpreters available, they're not always utilized. And so in my experience, they've not been consistently utilized to create access to higher levels of care. And so it's also an additional struggle to find linguistically appropriate services for Spanish-speaking children who have autism spectrum disorder, and also who need support with eating disorders, which we're seeing an increase in. And so this challenge isn't unique to higher levels of care. I think it just shows the fact that we don't have enough providers. Only 7% of licensed providers identify as Latinx, and only 5% of licensed therapists can provide services in Spanish. So if we consider that, and we consider also that suicide is now the 7th leading cause of death for Hispanic children. From 2010 to 2019, Hispanic child suicide rates increased by 92.3%. And that was before the pandemic even struck, which we know has had a disproportionate impact on Black and Brown families. And that rate is also increasing for Black children. So think about the rates for Afro-Latino children. And we don't have higher levels of care that are readily available. One of the services that offers more intensive treatment consistently has had a wait list because there's just not enough capacity. And now almost all services for children have a wait list, given the mental health crisis that Frances was framing earlier. So that's creating wait times for Spanish-speaking families for all services, which was not the case prior. There are also additional systemic barriers that we face in schools, for example, where Spanish-speaking children are less likely to be assessed for learning disabilities, and their parents are less likely to participate in educational decision-making. So these undiagnosed learning disabilities often create frustration and low self-esteem, which look like behavioral challenges. And so with that, what ends up happening is that kids are being disciplined and they're being met with punitive sort of intervention versus actually being assessed for the root of the issue. And again, I would imagine that this comes back to not having enough Spanish-speaking psychologists who can do the assessments that the school requires to create an individualized learning plan. So, and gosh, there's so many challenges that we have. So the last one that I'll mention is the fact that we know about the impacts of intergenerational trauma. And if we know that only about 1/3 of Latina adults receive mental health support, then we know that we're leaving many untreated and suffering with ongoing impacts of traumatic experiences. And we also have the added challenge of trauma related to immigration and migratory grief. The conditions that led to the journey itself, and the experience once one arrives to the country, which have included separation from parents at times, adds to those barriers. So like I said, there's so many more things that I can share, but I think these tend to sort of straddle a lot of the challenges that we see consistently for the Latino community. I can't hear you, Francis.
More than 2 years, I still forget to mute myself, but thank you. You've painted a picture that I want us to come back to, and you really have created a scenario for us that leads us to a discussion about adult needs, particularly if those adult needs have roots in childhood and adolescence. So I'm going to turn it over to Brian and ask you, Brian, to share with us for a few minutes the major challenges that you're seeing.
Sure. Well, first of all, I'd like to thank you very much. Thanks to the Progressive Latino Fund for having us today. This is great. I wish we had more opportunities like this. And Tara, I had a feeling that you and I would overlap in what we talk about, because a lot of the challenges, while the different generational groups are very important, a lot of the challenges have an impact at a multi-generational level. Today the U.S. boasts we have the second largest Latinx population in the world, next to only Mexico. And we're 5th in the world for the largest countries of native Spanish speakers, which blows me away. So the need for mental health services is growing. And unfortunately, the COVID pandemic has made this need, has exacerbated this need, made things worse. Studies have shown that more Hispanic adults report a need for emotional support as a result of the pandemic in comparison with their white and Black counterparts. At the same time, their rate of self-reported stress is higher than those groups. And so we have growing need and really a paucity of resources and workforce, and really access to care in general for this population. There's a stark imbalance between those two things. The couple things that I would like to highlight impacting adults really is poor coverage. This is particularly true for our immigrant population, institutionally underserved, but also poor coverage, forcing them to pay on a sliding scale that is often inadequate. Sliding scales in clinics like mine are often geared towards less frequent services. And with mental health, if we talk about the traditional weekly service provision, we're talking about $25 per visit, which adds up to $100 per month, which I don't know too many graduate students that would want to afford that new cable bill that we've just asked them to pay. And this actually is an interesting thing because for the immigrant population, it interacts in a very unfortunate way with some traditional Latino cultural values, where it makes it it's a very much a huge faux pas to not pay for services rendered. And so we're offering support, but oftentimes creating a new problem by having a bill that I think is too large. Beyond coverage, we also have simply inadequate services. What's typically highlighted is a lack of culturally and linguistically appropriate treatment. I mean, frankly, clinical research, just like most research, is performed usually with white college students. I used to joke around that we know a lot about white college students. And so, in recent decades, we've made strides in this area and have developed some culturally appropriate treatments, but we still have a lot of catching up to do. With the advent of the pandemic, we have a new issue where our population, the Latino population, faces a lot more issues with poverty. And so this creates a new access issue related to services where they often possess inadequate technology to participate in these new awesome services that we're able to provide in the virtual context. Workforce is always an issue. I'm proud to say that at Fairhaven, 11 of our 18 providers speak Spanish, and pretty much everybody is culturally fluent. And I wish this was the case for other places. We often find ourselves using terms like, we're looking for a diamond in the rough or a unicorn. And for us, it's not a unicorn. It's just a horse. We need these people. We need Spanish speakers. We need people that understand the culture. And so we sit and we wait around for this person to come to us, and they often don't. We've had openings for months at times when people are sort of waiting to be seen or continue their care. Another thing that we face oftentimes is low outreach and engagement with the community. We don't go to them. And this is extremely important, especially I think for the adult Latino population. They've been raised in a place where it's almost, it's adaptive to fear institutions at times due to an unfortunate history of discrimination and outright harm done to them in healthcare and other institutions. Some people in the research will call this a healthy paranoia of services rendered. And so there's a lack of trust there. We need to go out. We need to show them that this is us. We are here to help. We're not here to harm you. And we feel terrible about what's happened in the past and really start to rebuild these things. And those efforts really, you don't see them happening too often. They do happen when there's a crisis. Somebody in Fairhaven is shot or something happens and we go out, but then that disappears, and it needs to become more of what's normal in the community. Because this is related to your population, Tara. Parents are teaching their children. And so if we can mend these relationships with their parents, they will teach them a different lesson, I think. The other issue that I would like to bring up is retention of patients in care. We get them in, we have the services, but a lot of times Latino adults will drop out. If you go to see a psychologist, traditionally, that means you're crazy. One clinic that I used to work in, it was called the Hispanic Clinic, and la gente, they would say, La Clínica de los Locos, the crazy people's clinic. And everybody would laugh about it. I think we need to stop laughing about that and really take a hard look at why we're calling it that, because it's unfair and it's really not true. But meeting them where they're at in their community, it absolutely is true. And so we need to get out, and this sort of ties in with my spiel about outreach and engagement. We need to get out and change that narrative. So that's kind of what I wanted to talk about today in my opening. And I really look forward to discussing this further.
Excellent. Thank you so much. You've really lifted up a bunch of issues that are really the confluence of them makes for what we might call a perfect storm, right? And so really looking forward to unpacking those and discussing them further. Let me turn to Leonora and ask you, Leonora, to speak about what you know as a social gerontologist about mental health in the elder community.
Sure. Thank you again for having us all here, and thank you to my fellow panelists. Honestly, everything is going to lead on to the next. It's a domino effect from childhood, adult, and then to our older adult ages. It really is one full conversation of the person. If we don't look at the person when they're a small child and assist them with what services what are needed for them, then when we get into our mid ages, it's going to be a little bit more challenging to approach. And the other end, the last part of the spectrum of life in older adult age, you're looking at the person where they are who they are. I mean, we are who we are regardless, but we're not going to really change that much once we get over 65. We've lived our life, we've raised our children, we've had great careers, we hope. We've done everything we wanted to do. So a little bit about being a social gerontologist before I go on. Gerontology is a study of aging. So when I look at aging, I look at it not just at 65 plus, but I do look at how it all combines with the rest of the lived experience. If we have an older adult who has had childhood trauma that was never resolved because they never went to receive proper mental health services because of stigma, as Brian had mentioned, then we're going to have a person who's not quite ready to connect with themselves in their older version. So in my area, I really want to talk a little bit more about social isolation and loneliness. Those two key parts there, their counterbalance and what we want the older adult to really focus on instead of social isolation, loneliness, is social connectivity and resilience. One great thing that a lot of us do gain as we get older is resiliency. We manage to make it through the storms of life for the most part, and we're then able to kind of say, aquí estoy, here I am, I made it this far, I've done everything I could. But we find that many adults don't have that ability to gain that full-on resiliency because they are still struggling with the isolation portion of it. We see during COVID-19 and 2020 and 21 that social isolation had really become a conversation of forefront of older adults. It's always been that way. We've always had older adults who have been lonely and isolated. We have a good percentages of older adults who live alone here in Connecticut and throughout the US who are disconnected from others. So when we have this isolation, we end up becoming more, within ourselves. We see the increases of depression in older adults. That's one of the main things you'll find out when it comes to mental health is depression and increased anxiety. So, and those two are really because they've dealt with stressful life events. They've lost a spouse or good friends, family. They've had to move from their country of origin. If in the case of many Latino community members, they had to move. They're now dealing with chronic illnesses, with medications that make them feel not that great, to be honest. There's just so much that needs to be unpacked in this particular group, that the earlier that we have a diagnosis and we have that support through our community and advocating not only through the child end of it, from the youth, and saying it's okay to seek out services, and then as an adult, hey, it's okay to seek out services, you're not crazy. Then as we progress into the older age, it's going to become more and more acceptable. So Tara ends up on her end successfully getting the kids to where they need to be. Brian hopefully will have more folks that'll be able to really engage in these services. And then by the time they're in my area, they'll really say, here I am in the portion of my life where I can enjoy myself, my family, my grandkids, and have a moment to breathe out. That's an important part of as we age, is to be able to have that connection. As I was thinking of this presentation, I thought of a movie called Encanto. I'm sure a lot of you have heard of this movie. I'm sure a lot of you know it, and maybe in the sense I'm thinking of, which is it's all about mental health, to be honest. Look at Abuela Alma. Here's this woman who, in the beginning, you see that she had to leave her country. She had to leave. She had to leave everything she knew behind. She lost her spouse. She had to raise 3 children on her own. And she's dealing with the weight on her shoulders of keeping the family together. And that's what I've seen in a lot of Hispanic household, is that, you have your older adult that still wants to keep them together. If you don't have that person, you will become that person, at life. And we need to be able to remind them that the burden is not theirs alone, it's to be shared. That's one of the beautiful things we have in the Latino communities, that we can share it with La Familia. La Familia is exactly what we have, was that we have each other when we have it. When we don't have Familia, we have to look out for community resources and those individuals who can speak our language and knows our culture and knows the way that we can, knows us in a personal level, in a matter of speaking. So going back to Encanto for a second, We talk about, actually, we don't talk about Bruno. And who started not talking about Bruno, but Abuela. Abuela did not want people to talk about her son who was struggling with mental health issues. They shunned him, they pushed him away. And, you know, she really set the stage for that family's issues. I know this is a cartoon, but but it's a really good one, you know, and it really still talks about how, you know, we should really look at the family as a whole and not just stop it at just children, that conversation, or just as you know, working age adults. We need to include the older adults in this conversation. The other end of it, I want to talk about that social connectivity and the resilience for a minute. You know, we need to help support the older adults meet the challenges of aging. We have to look at how we can socially connect. And what I mean by that is, who do we interact with? If it's not family, are we interacting with our community members? I'm in a senior center, a Milford Senior Center. Are you connecting with your local senior centers where we have a lot of evidence-based programming and activities? We have nutrition programs. We have opportunity for socialization. We need to get out there to help, you know, so when I mean older adults. Older adults need to be out there, but ourselves as the adults, as the grandchildren, as the children of these individuals, need to say, hey, you know what? Maybe it's time for us to go out for a little while. Maybe it's time for you to go, you know, play some dominoes over here in Casa Otoñal or something like that. We need to get them to come out. And sometimes in that, gaining that that community connection, we find that they meet others who are going through the same issues and problems, and can connect. And hopefully in those locations, we have those key, you know, culturally competent community health workers and social workers, et cetera, that can really guide them. So if we can get them to those places, we can help support them. I don't know if I went through 5 minutes or not, but I did stop.
Okay, well, let's all come together now. I'm really, there's so much. I've taken pages of notes here in this conversation, and I really want this to be a conversation among us. So for us to interact with one another and ask each other questions if we have them. So I'm gonna kick it off. I'm gonna start with the point that you made. Both you, Tara, and Brian talked about the lack of Latino or Spanish-speaking, multilingual even. One person wrote in the chat about wanting to know, like, what kinds of services are available for people who only speak Portuguese, because I think this affects, you know, all immigrants from everywhere. But of course, we're talking today about Latinx folks, and Spanish is the prevailing language. It really struck me when you said, Tara, that given the population of Latinos in this country and Spanish-speaking people in this country, that we have such a dearth of clinicians. And so I want to explore that a little further in terms of what's being done to create a pipeline of clinicians. And is there also, there's an A part to my question, what's being done to develop clinicians? The B part is, how about non-clinical staff, non-clinical resources like community health workers that can in fact be a linchpin between the families, the children, their families, the elderly, and the services that exist? So let me ask you, Tara and Brian, to take that for a moment, and then we'll keep going.
Sure. I wish I knew the magic answer. I can tell you that there are certainly some programs that offer a focus in Latino, sort of Latinx mental health care. And so there is expansion of that. I think more recently, we're seeing some more programs expand, which I think is really interesting. Some of the challenge, though, is that some of these programs are luring people to stay on to do doctorates and do research, which we also need. right? Because we need research that is specifically done with our communities in mind and testing the efficacy of different interventions on our communities and developing them. But it does mean that they're sort of in the program longer and not coming out into providing the care as quickly as we need them. So I know that's one of the challenges we've seen. We're fortunate that we have about 7 or so Spanish-speaking clinicians available, and we also have our support folks who answer the phone in Spanish. So people are able to be greeted in the language that makes the most sense to them, and that speaks the language of their heart the minute they call. So that's one less barrier. So we know we create friction between when someone calls and when we can engage with them. They often drop off and don't engage, which brings us to the other challenge of the wait lists that we're seeing now. So
Right. So the Yale Child Study Center specifically does have clinicians, and it has changed some of its practices, like answering the phone in Spanish, which makes a big difference, right? Because you can catch someone right off the bat. I imagine, Brian, you may have something to add to that as well.
Yes, in behavioral health, we have 3 administrative support staff, 2 of whom are patient navigators, and all of whom speak Spanish fluently. 2 are completely bicultural, and I think that's very important with relational development. I mean, thinking about traditional Latino values, that patients often want to get to know you personally. And this is time where you have to be a little gray with certain ethics and boundaries, because it's important in relationship development. And oftentimes the you that they want to get to know personally is the program itself.
Right.
We all know, we've all had a place in our life where we just feel comfortable going, whether it's a restaurant or your bank or whatnot. And so I think that our administrative support staff, being bicultural, bilingual, really serves to create that welcoming environment. Oftentimes, pretty much all the time, they're the first person that they connect with. And so our messaging is all in Spanish and English. And really, while we will hire clinicians that don't speak Spanish, it's really hard to have administrative support that doesn't speak Spanish, frankly, and any other languages that we can get as a bonus. And to answer the question about Portuguese, just to pitch Fairhaven Community Healthcare, because I love it so much, we have a new Portuguese speaking psychiatric APRN who's wonderful, and we're accepting referrals. So but I think one thing that happens too is that we get there's a little bit of learned helplessness going on with hiring, I think, because it's so hard to find these unicorn-esque type providers, we sit around and wait for them. I think I use those exact words in my opening. People are often convinced that there's nothing you can do wait until help arrives. But I think, especially today, since it's getting longer and longer, there are things that you can do. Understanding the culture is almost as important as understanding the language. And a lot of kids these days are speaking English. And so it becomes even more important than the language. You do come across people that are bilingual, but they really don't understand the culture very well, and they miss out on things, and that contributes to dropout, contributes to poor care. And these are things that you can do on your own time. There's a number of courses that you can take CEUs for, or frankly, even searching for 10 minutes online and learning about, well, how's Puerto Rican culture different from Dominican culture? Be careful with that one, by the way. But and really just explore. I think that we look at this at Spanish as sort of the ultimate gatekeeper, but you can serve the population without knowing the language. But that said, also try to learn the language. There's lots of great apps out there. It's easier to get what we would traditionally get in the classroom these days via the internet. Practice.
Well, actually, I want to go back to both Tara and Leonora about this issue of the language and whether you need to speak Spanish or not, because I actually think I've seen some of those translation programs that they use in the emergency room, and they're tough for a person. They're tough because they're, and the technology, it's also impersonal. So let's come back a minute to to this discussion of having people who are both linguistically capacitated and who have an understanding of the multiple cultures, because Latinos, Latinx, Latina is not a monolithic, homogenous. There are different cultures. You alluded to the difference between Puerto Ricans and Dominicans, the difference between Caribbean Latinos and South Americans. And, you know, there's just a vast number of differences. So Leonora, do you want to jump on that for a minute? And then Tara?
Sure. So language is very important, especially in the older adult community, if there was their first language. So I like to use my mom as an example. She's going to be 80 years old in December. And my mom has been here since she was 16. And she knows English, but her Spanish language is what she goes to. It's what we spoke to in the house. We still do. She'll speak Spanish to her grandkids. And it's important for the people who are explaining to her medication or treatment or whatever it might be to speak that language. It's much more important than anything else, to be honest. She appreciates that her doctor, even though her doctor himself is not Latino, does speak fluent Spanish, and it makes her more comfortable to engage him in conversation and really get into what is that is bothering her. So it's absolutely 100% important to have clinicians, doctors, social workers, etc., folks that are in the field working with older adults to know the language of their preference or that is stronger to them.
I think it's a both and, you know, I think that learning to practice in culturally humble ways that we're learning about each family's unique expression of the culture. You know, I grew up in New York City. I'm Puerto Rican, but my experience is different from my cousin's experience, and we're both Puerto Rican, right? So being able to train clinicians to pause and ask each family about their unique expression of culture is one piece. And the language is another. I'm a Spanish language learner. I chose to learn Spanish as I grew up. I grew up at a time when assimilation was considered king. And there was an idea that if we assimilated, we would be accepted. We know how that works. But being able to sit with a family and have someone who's maybe trying to express themselves, I know they always jump to Spanish, if Spanish is their first language, when they are getting into these like kind of primal memories. And so to have that language ability, I think offers a different level of support. So I think you can support a family by being culturally humble. And so I think people can be of service in that way, but I think it's sort of deeper when you can add the language component as well.
I want to shift to the role of chronic stress, because all of you in one way or another referred to it. And Tara, you did mention seeing an increase in needs for autism care, needs for treatment of eating disorders. And how about chronic stress and the impact of that on mental health, you know, when folks are dealing with income insecurity, housing insecurity, food insecurity, and the like, or maybe not, but still chronic stress. Brian, you want to jump in?
See, I think this is, I mean, with Latino adults, mental health symptoms often manifest physically. It's highly recommended when working with Latino adults, you take a biopsychosocial perspective in your evaluation. Think about back pain, other things as having its origins in the human psyche and in their anxiety and depression and the goings on in their lives. And I think that we have regardless of the diversity, we have a very underrepresented, underserved population. And what that means to me is that they also experience more stress than the majority. And so when you have a really sort of a very interesting confluence of a culture group that often is sort of expresses their difficulties physically, and they're facing more of those difficulties, and so it's really an unfortunate picture that we're painting for people. And so I think that you know, the more and more things continue, and things really, especially socially and institutionally, aren't getting better, we're going to see an outward manifestation of stress as our sort of presenting concerns in the adult Latino population in the mental health care. And it's our job to figure out, what how can we help and in a culturally appropriate way.
There's a book called The Body Keeps Score.
I'm sorry.
And there is a book titled The Body Keeps Score. And it really is an analysis of how traumas, unresolved traumas and stress actually do manifest themselves in chronic conditions. And so this is really why when I opened up, I said, our health system separates our mental health from our physical health in ways that are just totally inconsistent. But some of the models that I've seen, and community health centers actually are lead in this area, is really tying together the primary care with behavioral health care as well, co-locating it so that folks can get the kind of referrals immediately that they may need. I want to go a moment to the points that you made, Leonora, about social connection and its impact on isolation and loneliness. There are different kinds of programs. I would say probably not enough of them for the Latinx elderly population in Greater New Haven. We're speaking, about Greater New Haven, but those kinds of programs really do go a long way to keeping people connected to one another and to community. Can you say a little bit more about the kinds of things that you have seen work for older Latino adults to mitigate the effects of isolation and loneliness?
Sure. So often with Latino communities is going to be more of the informal systems, church groups, religious groups. I always tend to use my mom as an example, but she has her Rosario group, and they meet together, and then they go to a soup kitchen and they volunteer together. So it's these informal things that seem to work, at least in using my mom as my key example here. But joining in different type of civic organizations and family events and events and times that they spend with their families is really what some of the key supports for older adults in the Latino community. It's always going to focus back around that community level. When we look at more of the formal supports, as I mentioned, the senior centers, social service agencies that are more focused on the Hispanic community is going to be what is going to best support older adults. The issues with that might be getting them to actually attend a senior center or attend those type of formal places. And a lot of times I find that I'm generally the key person that a person will call or they'll email, generally an adult child or a grandchild, and gee, mom or dad is stuck in the house. They don't want to get out. I work. I don't want them to be alone. I want them to do something. So all the time I'll get on the phone or I'll invite them. I'll say, hey, you know what? We have a free lunch here waiting for you. So I'd love to have you come down as my guest. And a lot of times it's like, ooh, free lunch. Let's do this.
Yeah.
There's always a catch to it, but once they are able to see that people are just people enjoying themselves, and they get to see all the opportunities that they can actually take part of and that they're missing, they'll say, well, gee, wow, this is different than what I expected. So when we look at more of those formal places like the senior centers and community centers, they just have to see themselves there by actually going there. And that's always going to be the biggest challenge of it. So for the younger adults, those grandkids, adult children, it's really reaching out to us, reaching out to those who serve the older adult members of the community and asking us. We are much better than Google. Don't Google things and look at, just give us a call and say exactly what I said. Hey, I have a older adult parent, grandparent, etc., and they need some support. Can you help me out? And we're always happy to provide that support to them in the language of their choosing, of course.
And one of the I think unique characteristics of Latinx families still is the intergenerational nature of our families. And like the young people that you see, Tara, and their parents have an older adult or two or three in their family, right? And the folks that come to Fairhaven Community Healthcare also could all be like members of the same family, seeing different clinicians because they're all going there. There feels to me like an opportunity for intergenerational connectivity between young people, the children, adult children who are trying to do that work, to do the juggling between the young children and the elderly parents and the older adults. There was a project many years ago that a teacher in New Haven led with her high school students, having her high school students do an oral history of Latino seniors in New Haven by having them videotape interview them and video them. And they created a beautiful documentary. They went to Casa Colonial in New Haven on Sylvan Avenue, and they interviewed, 24 seniors who live there. And these high school students gained such an appreciation for the history, the culture, and the experience that these older people had of living in Puerto Rico or other countries and coming to the United States and all of that. And that creates community, which is really what everybody needs, right? In addition to clinical attention. I want to shift to a couple of the questions that are in the chat. And Brian, you mentioned the sliding fee scale and the impact that has on folks, because mental health services do tend to be more frequent than physical health services, depending on what the physical health conditions are. But having to pay on a sliding scale can be helpful, but still a burden. And so one question in the chat has to do with insurance issues and coverage issues, I think, in general, because some families are on Medicaid, Husky, others are uninsured, others have employer-sponsored insurance. What are you seeing with insurance? What are they covering? What are they not covering? And how is that a barrier for people?
I'd say coverage is generally good in Connecticut when with regard to basic behavioral health services. Now, we don't offer currently psychological testing. We do under the guise of developmental behavioral pediatrics, but that's billed more under our medical side of things. And so generally, I think that I don't think we've achieved the level of parity with medical health coverage. If people are insured, coverage tends to be decent. I think the larger copays that I see are $50 or $60, and that is a lot, quite the burden for people. I think that clearly the immigrant population, the undocumented immigrant population, is one of the major barriers, is just being uninsured and having to pay on that sliding scale. And so, luckily, I have a very supportive, leadership staff, and we're working on exploring ideas for a behavioral health specific sliding scale. So, but and that's true for just about anybody. I mean, I think now that we have the Affordable Care Act, that there's less people that are uninsured, of course, but again, it disproportionately affects our immigrant population.
We know that commercial insurance is actually less But the coverage under commercial insurance is less than it is under Medicaid. I'd like actually to go to Tara and pose to you a couple of things. One is I see that you would like to address the increase in suicide, which we know is a crisis among young women, young girls, right, 12 to 17. So if you could add more dimension to that for the Latino community, and then also immigrant coverage through Medicaid. Last year, the state legislature expanded coverage to undocumented immigrants for the Husky program for children 0 to 19. It's actually 0 to 8 first. Those folks, those 11,000 kids can stay on to age 19, and then they added another group of children up to age 12. But could you address both of those issues?
Sure. So I actually wanted to go back to some of what Leonora was talking about in terms of the isolation, right? And so some of this, you can be surrounded by people and still feel completely isolated. And when your parents, your caregivers are firmly holding on to the culture of their home country, while you as the child are trying to navigate the place you live, and you're constantly being given messages about you're not being, you uphold your culture, you're not doing this, we're supposed to do that, you're too American now. While the kids are just trying to find their way, it can cause a lot of struggle. So to me, that feeling of isolation, that makes some sense to me, that there's an increase in some of the suicidality because of that. You feel more isolated, you're sort of straddling two worlds, where you're trying to sort of hold your culture and sort of honor your parents' expectations while also trying to navigate the world you're living in. So I think those are two pieces. I think another piece is that, and this goes back a little bit to your question before, Francis, about kind of access to services. Children are often the gateway to services for the adult caregivers, because the children, the parents will bring their kids in. But for many, it's the first time they've ever been in the presence of any mental health support. And so the clinicians are often spending a great deal of time providing psychoeducation and support to the families to then try to connect them to other services. So there's that piece. And then with the increase, like we did have a sliding fee scale for behavioral health here, and we tried to make it accessible to undocumented families and created a process in which we actually would sit with them and have that conversation about why are we even filling out this paperwork, because there was always concern about, I don't want to give you more information, I'm worried. So with the shift with Husky, we were able to see more families come in without the barrier of worry of if I fill out this paperwork, am I somehow putting myself on the radar and being vulnerable? So we have seen an increase in families that are accessing the treatment. Now the challenge is finding the places to connect their uninsured parents.
Right. And those waiting lists that you mentioned earlier, which are so long. I was trying to help a neighbor with a young adult who needed treatment, and the waiting list everywhere was so long. They were so long. So, but I want to also go to the relationship of the community-based treatment options to the schools. Is I know that, the schools too are a place where there can be services accessed by parents for their children, by children directly. And the legislature, I believe this year, did appropriate additional funds to school districts through the State Department of Education. What is your relationship with the school districts in terms of young people?
Well, they're part of the system. that the children are in. So we have constant contact with school systems, and our clinicians are constantly providing education, guidance. We often share some of the strategies for the kids who are engaged in treatment with us that might be translatable into the school setting. Offer ways for them to be able to understand some of what's going on for the family and be able to intervene. But it's huge. I mean, it is an amazing opportunity when there's like a school-based health center that has culturally and linguistically diverse clinicians. Like that is like hitting the jackpot, because you are able to intervene in the school and have someone who is part of the school community who's called in on a number of different levels to support the children. So we're always in touch with the schools and we work in partnership with them. But the schools also have a number of stress and strain, and we can do a whole other forum on that. And
I hope we will. And I hope we will. Yeah. I told you we wouldn't have time to cover everything that needs to be covered. I have a bunch of questions. There's still questions in the chat, but I do want to I want to ask you all in the last couple of minutes that we have to answer a question. What keeps you hopeful for the people you serve? What are a couple of measures that policymakers can take to address these problems that you've identified of shortages of the workforce, destigmatization of mental health needs, and connecting people to services? Any one of you can jump in first.
Well, I think one of the barriers so what keeps me hopeful is that, you know, I've been in it for the long game, right? I've been in this field for 20 years and I have seen shift and evolution. I'm really inspired by the newer generation of clinicians that are coming out of school, because they're also, and kudos to their programs, who are also training in ways that are much more, it shifts to this idea of being culturally humble versus culturally competent, which I think is a dangerous place to be, to consider yourself culturally competent. So that gives me a great deal of hope. And I think the strategies is really thinking, one of the strategies is thinking about the way that mental health care is reimbursed, because that has a direct impact on the salaries that can be paid, the number of services that can be offered. And it makes it hard for people who would like to do this out of passion to be able to afford to do it in many ways. So I think increasing the reimbursement rate is one thing that could help.
Thank you for that.
I think what gives me hope is the people themselves, and not just the Latinx population, everyone, I think. But within the Latinx population, despite the stressors, they have shown to be such a resilient population. And I hope that there's not so much to be resilient for in the future. But, you know, the immigrant Latino population is well known for being resilient, being this adventurous group that has decided to move to a different country and start a new life. And so we have things like the immigrant paradox, where while you would expect very poor outcomes upon their arrival, those outcomes don't necessarily emerge, that there is a certain inner quality within the community and within the individuals themselves that serves as a protective factor in many ways. And I think we're seeing that manifest in the fight for visibility, and the population is growing, the voice is getting louder, and I think that it's wonderful to see. On the other side, we're seeing that mental health issues can no longer be ignored. Just looking at the state of Connecticut and the movement, there's a lot of, oh, we should have done this a long time ago. We need to catch up. We need to do this. There's a lot of great conversations and some good products coming out of it. I know we all get exhausted with politics and the talking points. We're seeing things actually emerge, tangible products that can be, employed to help the population. And so I feel hope in that, in what I'm seeing And then just the evident natural qualities of the population that we serve that's really fighting for itself. And so with on top of
It's the
that,
collective, the personal power and the collective power.
yeah,
I think you're talking about. I'm gonna give
absolutely.
Leonora the last 30 seconds and then turn it back over to Jadi.
Well, we are growing. The Hispanic community, Latinx community is growing. Right now, of older adults 65 plus, it's about 9%. By 2060, it's going to be about 21%. We are growing. We're growing older. We're growing. We're going to be able to be this group that makes a huge difference. Myself and my fellow panelists here are all working to ensure that the individuals in our communities are able to get the support they need. We start with the young and we pass it through the lifespan.
Yeah, that's right. We're all in it together. Well, thank you, all three of you. This has been wonderful. I hope we get to continue this conversation and take it down the different lanes that it needs to go on. And Jadi, I'm going to turn it back over to you to close us out.
Thank you, Francis. Thank you, Tara, to Brian, to Leonora for such a rich discussion. I think we took notes on a few other items that I think need additional discussion. And so this will build the agenda for our forum schedule moving forward. I want to thank our audience for actively participating. I saw a lot of questions coming through in the chat, and thank you, Francis, for pulling those out and helping to answer some of those with our panelists. I do want to urge you all to complete the survey. There is the link to the survey. Your feedback is important to us. We do this work because we want to be able to bring to our community issues that are important to you. So here is your opportunity to share with you how did this feel? Was this good? Was this bad? We want to hear it all. And if you have thoughts on what we might be able to prepare for you in the future, then tell us about that too, because we're really interested in hearing. So thank you all. Have a great rest of the day. And thank you again to our panelists and our moderator.